name is Christopher Kennedy, and today I'd like to talk briefly with you about porphyria and its implications in regards to anesthesia delivery and management. So, let's get started. First off, I'd like to discuss what porphyria actually is. It's commonly recognized as a group of metabolic disorders, each of which resulting from a specific enzyme deficiency in the synthetic heme pathway, resulting in an overproduction of precursors or porphyrins. These inborn errors of metabolism are characterized by the overproduction of porphyrins, which lead to an exacerbation of the underlying type of porphyria. Porphyrias are classified as either hepatic or erythropoietic, depending on the site of overproduction or accumulation of precursors or porphyrins. Here is the metabolic pathway for heme synthesis. On the left of the pathway, enzymes are noted on the feedback inhibition loop of the sequence, and the type of porphyria associated with the enzyme deficiency is noted on the right. The examples of the acute porphyrias are indicated by the bolded lettering, and those are the acute intermittent porphyrias, the hereditary corporoporphyria, and variegate porphyria. Let's just take a moment to answer the question as to what actually a porphyrin really is. Porphyrin is a byproduct of metabolism via certain enzymes that enable a particular sequence of events to take place. A defect in any of these enzymes results in accumulation of the preceding intermediate form of porphyrin and produces a form of porphyria. Porphyrins are essential for many physiologic functions, most importantly, oxygen transport and storage, the most important of which in human physiology is heme. Now, in terms of the general affected population, there isn't really much of a discretion as to which population, ethnicity, or background that porphyrias affect. Both men and women are equally affected, to where there's no influence on gender or inheritance. Most commonly, it's an autosomal dominant condition, meaning that it's inherited by only one family member, either the mother or the father. With that being said, most documented attacks or exacerbations are in women, and these attacks are less likely to occur prior to puberty or after the onset of menopause, and that's thought to be related to the production of progesterone. With that time frame being said, these exacerbations and attacks most often occur in the fourth and third decades of life. Also, pregnancy in these patients, being that it's primarily women, often results in a spontaneous abortion. Acute attacks are most commonly precipitated by events that decreases heme synthesis concentrations and increase the activity of ALA synthetase, causing production of porphyrinogens. Patients with a history of porphyria and, say, iron deficiency anemia, hemolytic anemia, cardiovascular disease, or respiratory disease are all specifically predisposed to acute exacerbations of their underlying porphyria, related to the increased activity of ALA synthetase in the effort to produce more hemoglobin. In terms of its being diagnosed, mostly due to its vague and common symptoms, diagnosis is often difficult because it mimics so many other disorders with its symptoms, which we'll get into that next. Many of these patients show no biochemical abnormalities, so it's kind of at that point when care is turned and focused on obtaining a good detailed family history. In the presence of a suggestive family history, determination of the erythrocyte porphobilinogen activity is the most appropriate screening test for patients with suspected AIP. The presence or absence of peripheral neuropathy and autonomic nervous system instability should therefore be noted. Also, during acute exacerbation, urinary levels of the porphobilinogen deaminase, or PBG, are typically elevated. Just to kind of go through and tell you and show you some different classifications of porphyria, here's a list of those varying degrees. It's important to note that all of the hepatic porphyrias located on the left are considered the acute variations of porphyria, with the most influential ones being, in anesthesia, being the acute intermittent porphyria and variegate porphyria in terms of their harmful potential. And these are going to be the ones that I'm going to focus on throughout this presentation, particularly AIP and its management. Signs and symptoms with these can range from a variety of bodily systems. The most common and most often presenting symptom is this severe abdominal pain. This typically experienced during an acute exacerbation, and that's kind of thought to be related to the autonomic neuropathy that can generally be caused by these porphyrias. The tachycardia, the hypertension, the hypotension, less commonly seen, is often related to the autonomic nervous system instability. Electrolyte disturbances, particularly those in relation to the sodium, potassium, and magnesium, are generally seen. And seizures, hallucinations, and even delusions are also part to the neuropsychiatric disturbances that's seen. It's important to note that levels of ALA synthetase are elevated in all the acute exacerbations of porphyria. With that being said, these primary ones affecting anesthesia, let's focus on the varying degrees of porphyria and talk about the two primary forms that can have a direct influence on us. It's important to note that AIP, or the acute intermittent porphyria, is in fact the most serious and influential and carries the most potential for threatening life. It's resulted from a defective enzyme, which is the porphobilinogen deaminase, or the PBG, therefore causing a defect on chromosome number 11. The systemic hypertension, the renal dysfunction, the intractable abdominal pain, and headaches are all thought to be attributable and related to the central nervous system and peripheral nervous system being affected. The variegate porphyria, or VP, being that it can be associated with neurotoxicity and the cutaneous photosensitivity, often these patients present with seizures and these skin eruptions and blisters when exposed to sunlight. The defective enzyme responsible for this is the protoporphyrogen oxidase, noted to be a defect on chromosome number 1. Getting into how it affects anesthesia directly, drugs that often induce the cytochrome P450 mechanism of induction and metabolism are thought to be linked to the acute exacerbation of porphyrias. However, anticonvulsants aren't thought to exacerbate the non-acute porphyrias, such as porphyria cutanea tarda or the erythropoietic porphyrias. Only the acute forms of porphyria are affected by drug-induced enzyme induction, and it's not clear why the manifestations of the non-acute porphyrias are apparently unaffected by enzyme-inducing drugs. Particular care is needed when selecting drugs for patients with AIP or clinically active forms of porphyria, and when prescribing drugs in combination, because exacerbation of porphyria is more likely under these circumstances. The labeling of drugs as safe or unsafe for patients with porphyria is often based on clinical experience with the agent and the reports of its induction or lack of induction and acute attacks. Just some kind of general guidelines for selecting different and varying drugs with these patients. It's not possible to predict what drugs are going to be porphyrinogenic, although chemical groupings such as the allyl groups that are present on barbiturates and certain steroid structures have been scrutinized in the induction of porphyria and acute exacerbation. It's likely that exposure to several potential enzyme-inducing drugs may be more dangerous than exposure to any one drug itself, so therefore the anesthetic plan must take this into consideration. Also, I would like to note that the American Porphyria Foundation maintains up-to-date information on all aspects of these diseases, and a drug database with information about drugs and acute porphyria can be found at www.drugs-porphyria.com. In terms of prevention and prophylaxis, there's no specific therapy that's been shown to be clinically effective in reducing the occurrence of acute exacerbation. However, diets that are high in carbohydrates have been shown to provide remission and provide prophylaxis with these patients. It's believed that because carbohydrate administration can suppress the porphyrin synthesis, administration of oral carbohydrate supplements preoperatively may be recommended as a prophylactic measure in preventing an acute attack or exacerbation throughout the whole entire perioperative period. And oral feedings aren't able to be tolerated, which generally we want these patients to be NPO before we take them back to surgery, so oral feedings aren't necessarily ideal. So in that case, an infusion of 10% glucose solution and saline is often an acceptable alternative. Some of the pre-op medications that we generally give to most patients undergoing anesthesia are pretty well tolerated, such as the amnestic and anxiolytic drugs. Care should be focused at that point in the pre-op administration of medications in preventing an acute exacerbation, as well as preventing exacerbation in general. Interestingly enough, I want to note here that cimetidine or Tagamet has been recommended for treatment of acute porphyric crisis during this drug, since this drug may decrease heme consumption and inhibit ALA synthetase activity. Tagamet cannot, however, prevent an acute attack of porphyria. It is also important to note that Tagamet, given this recommendation, can potentially inhibit the cytochrome P450 mechanism of metabolism. allowing plasma levels of drugs that undergo that mechanism of metabolism to accumulate and have an exaggerated clinical effect. That's just something to kind of keep in mind and think about when you're using different drugs throughout your anesthetic. In dealing with the management of this crisis, if an exacerbation of porphyria is suspected during the perioperative period, particular attention must be given to the skeletal muscle strength and cranial nerve function, because often it's these signs and symptoms that may help predict respiratory failure and an increased risk of aspiration. Post-op mechanical ventilation may be required during acute porphyria crisis. Cardiovascular exams, such as just routine vitals, can reveal systemic hypertension and tachycardia, which potentially could necessitate treatment prior to the induction of anesthesia. Also, during acute exacerbation, severe abdominal pain may mimic a surgical abdomen. Patients experiencing acute porphyric crisis may be assessed carefully for fluid balance and electrolyte status, especially the presence of hyponatremia, being that these patients are prone for seizures. With that being said, in varying drugs, as far as the use or the presence of induction and use of varying drugs, etomidate is potentially porphyrinogenic in animal models, and there has been at least one crisis known in human subjects. Although its safe use has also been reported, on the terms of balance and just prevention and prophylaxis, etomidate should probably be considered unsafe and avoided if and when at all possible. Continuing our management throughout the perioperative period and postoperatively, pain experienced often necessitates the administration of opioids. Fentanyl, morphine, Dilaudid, all of those drugs have been used safely and effectively in the patients with porphyria and even acute porphyria crises. Gastrointestinal disturbances such as nausea and vomiting can be treated with conventional antiemetics such as Zofran or Phenergan. The seizures experienced with these patients, or the potential for seizures experienced with these patients, since the traditional anticonvulsants are regarded as unsafe due to their induction of the P450 mechanism, seizures may be treated with a benzodiazepine, typically Ativan or even propofol. Electrolyte disturbances, including hypomagnesemia, they must be treated aggressively with supplementation to prevent any further compromise in bodily systems. And typically those can be replaced per the protocol of whatever facility it is that you're working at. Again, I want to emphasize here to minimize the administration of drugs that can potentially induce the cytochrome P450 mechanism, thereby allowing you to avoid an acute exacerbation. If, however, throughout your due diligence and prevention and prophylaxis, if you come up on an acute exacerbation or crisis, the first step in treating an acute crisis is the removal of any known triggering factor. So take a look at what drugs you've given, where the patient stands, and just kind of think and process eliminate where you are. Adequate hydration and, again, carbohydrate loading are often necessary to prevent and deal with the occurrence of an acute crisis. Somatostatin, it decreases the rate of the formation of ALA synthetase, and in combination with plasmapheresis may effectively decrease pain and induce remission. Administration of heme is indicated after a day or two of the crisis if the patient is no better after receiving conservative traditional therapy. Heme may be administered as Hemetin, heme albumin, or heme arginine. It's presumed that the heme supplements the intracellular pull of heme and thus suppresses the ALA synthetase activity. Heme arginine is more stable than Hemetin and lacks the potential adverse effects associated with Hemetin, and those are renal failure, coagulopathy, and potentially thrombophlebitis. Being that it's considered more stable and doesn't have the adverse effects attributed to Hemetin, these attributes make it more clinically preferable than Hemetin itself. Also, in terms of determining what anesthetic choice to use, both general and regional anesthetics can be done safely and effectively, as they have for many years with these types of patients in this population. The care is focused on the drugs that you give and the ability to induce the ALA synthetase, as well as their characteristics of being porphyrinogenic. The total dose of drugs administered and the length of time exposed to specific anesthetic drugs may influence the risk of triggering a crisis in susceptible populations. The availability of relatively short-acting anesthetic drugs has likely contributed to the safety of anesthesia in the presence of porphyria. Perioperative monitoring should consider the frequent presence of autonomic dysfunction and the possibility of blood pressure lability. There is no absolute contraindication to the use of regional anesthesia in patients with porphyria. However, if a regional anesthetic is being considered, it's key to perform a neuro exam prior to the blockade to minimize the potential that may worsen any pre-existing neuropathy. Autonomic nervous system blockade induced by the regional anesthetic could unmask cardiac instability, especially in the presence of autonomic neuropathy, hypovolemia, or even both. There is no evidence that any local anesthetic has ever induced an acute attack of porphyria or neurodamage could be caused directly in the porphyric individual. Regional anesthesia has been used safely in parturient women and generally patient populations with acute intermittent porphyria. Regional anesthesia is rarely used, however, in patients experiencing acute attack because of concerns about hemodynamic instability, mental confusion, and porphyria-related neuropathy. I kind of want to include here on a little side note that in theory, patients with a history of porphyria and cardiac history that are planning to undergo heart surgery, primarily involving cardiopulmonary bypass, they pose a potential risk for patients, or this poses a potential risk for patients with porphyria because of the additional stresses introduced by hypothermia, the pump-induced hemolysis, and blood loss, and the consequent increase in heme demanded by the bone marrow, as well as the large number of drugs that are typically administered here. Care of these patients can pose a challenge to the anesthesia provider, and care should be focused on preventative measures as well as drug selection, also trying to avoid those drugs, again, that can potentially induce that cytochrome P450 mechanism. Also, the carbohydrate administrant and the heme administration can always be proven to be beneficial. Wrapping things up here in conclusion, the simplest course for the practicing provider to adopt is not to attempt to try to remember a large range of drugs that are potentially hazardous, but rather to develop a simple, safe technique based on agents that have minimal risk of triggering a porphyric crisis. Regional anesthesia with any of the currently available agents, is not contraindicated and may be beneficial when it's appropriate. There is thus a more than adequate range of pharmacological agents available for use in the porphyric patient. The choice of agent may be based more on the patient's anesthetic and surgical requirements rather than be governed by the specific requirements imposed by porphyria. And also here is a page of my references that I have used throughout the process of this presentation. Thanks again.